Everything you need to know about tearing or having an episiotomy. Stick around. Welcome to the Hypno-Baby channel. I'm Dr. Natalie Fizet. I'm a retired family doctor who delivered 3,700 babies. This is your channel, so don't forget to comment, like, share, subscribe, and be amazed. Of course, there's a big medical disclaimer. This channel is for entertainment only. You use it at your own risk. I am a doctor, but I'm not your doctor. Hi, I'm Dr. Natalie Fizet. So if we compare having stitches either from an episiotomy or tearing compared to the recuperation from a C-section, which is an abdominal surgery, 99.9% of the time, it's the lesser evil is vaginal birth, even if you have tearing or stitches or an episiotomy. You have to know that if it's your first baby, you have almost 9 chance out of 10 of having some kind of tearing. But like I said, sometimes it's very superficial and it heals well, especially if you do the right care, which we're gonna discuss. And stick until the very end of this video because I have like a treat for you at the very end. There used to be a time where they were doing episiotomies, and there's still countries where they do almost episiotomies on routine, and they're not indicated. We know for a fact that when what's an episiotomy? Let's start with the beginning. So, with imagination, my hand here is the entrance of the vagina. The baby's head would be coming here, and my knuckle here is my anus. Okay, so the perineum is the entrance of the vagina to the anus. That is what would tear 99% of the time, and that's what they cut when they do an episiotomy. They can cut either with scissors or a scalpel. I've never seen a scalpel, and that would be more dangerous. The baby's head, if you can imagine, is right there, so it could be easily like you could hurt the baby. So scissors, you can only take this, so you would not hurt the baby unless you're really, really not skilled. So there's two kinds of there's more than two kinds, but the two main kinds of episiotomy is median, which is like in the midline from the vaginal. Do you like my vagina? It's my hand. Vaginal entrance to the anus. And they usually cut like not all the way to the anus, they just cut here. But the problem is they're creating a weakness because if you see here, the baby stretches this and the tissues are the original tissues. So they have their strength. Once you cut, just like when you go to if you go to buy fabrics, what does she do? Was the sales lady does? She does one snip and then she goes, whoop. So you're creating a weakness. And often I've seen that once they did an episiotomy for whatever reason, which we're going to discuss, then it went like all the way down when the baby came out. So it's not recommended to do routine episiotomies anymore. Like I said, there's still some countries, but they need education because we know for a fact if the doctor doesn't or the midwife does an episiotomy, and it's always doctor or midwife, not the nurse that would do an episiotomy. So if they do that, they create a weakness and you're guaranteed to have stitches because you've already been cut. If we let the tissue stretch, and sometimes you have a minor cut, sometimes you have like scratching that don't need any repairs that would heal on their own. Just like if you're trying to steal third base in baseball and you scratch yourself, you just like peeling off some skin, so you don't need stitches, and you're gonna redo skin. Same thing, the vagina regenerates very fast because it's well vascularized, so you don't always need stitches even if you have like small tears. There are still some indications why you would do an episiotomy, but like I said, routine, it's not recommended anymore. The big argument when I was like a young doctor was, oh, we'll cut and it'll be straighter and it will prevent tearing. It doesn't prevent tearing. Like we said, it encourages tearing. The other thing about cutting to be straight, not true again, 99% of the time, because if I delivered a baby and the baby had a big head and my patient got a tear, it would tear in the midline because that's where the biggest force is, okay? So if somebody walked in, another doctor walked in, he would not even know if I did an episiotomy or if my patient tore, because the result would be identical. So all that thing about peeling different, it doesn't apply. There are still some indications that when you would need an episiotomy or where an episiotomy could be useful. The first one is if your baby is stuck there. What I mean by that, I've had patient pushing the baby and they want to go natural, so there was no question of doing an episiotomy. But the head would be like halfway out, and then she would push like two or three pushes, and the baby would not move, like you can see. And there's kind of criterias which are again not 100%, where if you cannot put your finger anymore between the baby's head and the soft tissues of the mother, it means like we're really at the max here. um, and the other thing is if the skin is all white, again that could be another criteria. But sometimes for some reason the last push, all those cells, at this point we're talking about cells, would give in and the baby would come out and there was no tear. And I would have sworn like, okay, it's been three pushes, the baby's jammed there, it's gonna tear. The problem, and I would discuss it with my patient between pushes, of course. When she's pushing she's busy, but I would discuss like, okay, you look like you're at your maximum stretching here. What do you want to do? Do you want to, go natural, or do you want me to do a small episiotomy, knowing that it could like go longer? Most of the time, they would choose just to tear naturally, and sometimes, like I said, I would have sworn like, okay, it's gonna tear, and it didn't tear. So somehow we found that millimeter that was necessary. The problem when it's really, really, really tight like this is that you could tear like in a star, like almost not explode, but almost. And then it's harder to put the little pieces. It's like little pieces. If you can see my hands here, putting stripe A with stripe B and going so forth. So it's kind of more sensitive. But again, it heals well. Okay, so don't worry about that. They say put warm compresses when to stretch the tissues. That helps. It's funny because I've had a nurse that would put like when my patient was pushing, she would put like a warm face cloth, but she would put it around. It looked like a turtleneck, and the baby would come out with the face cloth around. So that would be kind of cute. So the second kind of episiotomy is what they call mediolateral. So that's the entrance of the vagina. The anus is here, and they would go sideways because at this point here, when you hit the anus, you're at the maximum, but this you could go like further. The problem is that there's muscles here, what we call transverse muscles. And when they cut the muscle, you can feel it's like almost cutting meat. And many women after that, even though we repair good, they say it pulls when they're sitting, and it's a way longer recuperation because you can imagine the muscles are pulling. So it's very uncomfortable for the patient. So mediolateral is really when you need space. It would be for emergencies. Again, it should be discussed with you. There's always time between pushing, saying this is the situation. So when would an episiotomy would be like required is if they need to do a forceps and they're already like narrow in there with the baby's head and everything, and they need more space. That could be an option. The other thing is, as I was saying, like if my patient, if the patient is pushing and the baby is not moving and the heart is really low, the baby's heart is really low, sometimes a small episiotomy would, save the baby 5 or 10 minutes inside. With sometimes when they go down, their cord could get squished or for whatever reason. So there could be some indications, but they're actually pretty rare. If you don't want an episiotomy, and there's videos, there's simulations on the web, and just looking at it, you kind of cringe. And I've had 4 babies too, so I know how you feel. You don't have to watch them if you don't want to. There's real life videos also of stitching up, which is kind of maybe you don't want to see that. So if you don't want an episiotomy, put it in your birthing plan and discuss it with your nurse that welcomes you to the delivery room. Also, everything in your birthing plan, discuss it with your doctor at the office before. Birthing plan does not have any legal value, but at least you've discussed it and you're on the same page with your healthcare provider. A good way to have less pressure on the perineum and hence less tearing is to deliver on any position but on your back, because if you're on your back, the baby comes down and then it hits the wall being the perineum, and then it puts all the pressure on there, and then you can have more tearing. So if you had the epidural, you can always go on your side and then lift the leg, or there's other position, discuss it with your healthcare provider again. Or if you did not have the epidural, you can be squatting or you can be on your hand and knees, what they call on all fours, and that puts way less pressure on your perineum and reduces your risk of having a tear. If you're thinking, well, I've seen a lot of videos about perineal massages. Yes, I used to hand out sheets about perineal massages. I'll explain to you what they are and how they're done, but they have not been proven efficient. Sorry, another thing, but it wouldn't hurt to do it. And honestly, I had a patient that had a phobia almost of tearing, and she would do perineal massage almost all day long. And at the end, I could like pull her vagina and put my fist in. So of course she did not have stitches. The baby came out. So that was the extreme, but nobody does so much perineal massages. And studies said if you do more perineal massages, the tissues are going to get stiffer. So that would have the counter effect of what you're trying to do, which was not the case for my patient, but that's one case. So it's more anecdotal. So how do you do perineal massages? Again, back to my vagina here, my hand here. So that's the entrance of your vagina. If you do it yourself, you just lie on your back with pillow or breastfeeding pillow behind, and you put your two thumbs. You have to go deep. You have to go to the second joint here, and you go down. Don't go like down like this, because you have the transverse muscle here, if you see. So you're gonna be stopped very fast. If you put your thumb in and you push towards, like away from you, you could go to the other room. So you have room to do. And they say do little massages like this, like back and forth. Okay. And then they say go on the side and do it. If your spouse does it, again, your legs are up. Your spouse puts two index finger all the way to the second joint here inside. And you can always use almond oil or primrose oil or any kind of lubricant to make it like smoother. And all the way to the second. And again, the massages. I've had couple that came to my office and they were like, oh, we're doing perineal massages, we're ready for the birth. And I'm like, you're too happy, you're not doing it right. So a perineal massage kind of burns, because just like when when you pull on your mouth, like, you know, we used to do that when we were kids, but at one point it would get numb, it would get like kind of burning a bit. A good perineal massage will get the couples almost fighting, because they're like, oh, are you done? And so forth. So it's not a pleasant, it's not really a massage, it's more like a stretching, if we can say that. There hasn't been much studies, but the ones that have been done on primrose, because I know some women put primrose oil in their vagina couple of weeks before the birth to soften everything, has not been proven efficient. So you can do it, it doesn't hurt, but most probably it doesn't help much. You have to know that the baby, when it comes, is going to be the ultimate stretching. If you have an episiotomy, since they're cutting, like I said, it's a guarantee you're going to need stitches, most probably, because there's no teeny weeny episiotomy. So instead of letting go natural and maybe not having stitches, not needing stitches. And the other thing is, there's more bleeding, especially if they cut in the muscle, if they do a medial lateral. Sometimes it's necessary if your baby is quote unquote stuck and you cannot push it out and the heart is really like very low. It might be necessary. So don't reject every like episiotomy saying, Natalie said never. I never say never. So it there's more bleeding. There could be more infection too because it's an open wound, but it heals very well because, like we said, it's well vascularized. If you have what they call a third degree tear, is the first degree tear is just the opening of the vagina. Like I said, it's usually at the bottom. Sometimes you can have like two little on both sides of where you pee. You can have little scratches, but usually these heal very well and they're superficial. So at the entrance of vagina, that's a first degree. If you have the entrance of the vagina and lower, that's a second degree. The third degree is near the anus, and the fourth degree is the muscle of the anus. So you're split open. Again, it heals very well. Many women, if they had a third or fourth degree tear, will be scared of having a stool. So you can ask, well, it's automatic usually at the hospital. They will give you a stool softener. It's not a laxative, so you won't have diarrhea. But at one point, it's a vicious cycle. You're like, oh no, I cannot pass a stool. I'm afraid, I'm afraid, I'm afraid. And then you hold it in, and then it gets harder, and then the stool gets bigger. So just go, okay? Um, what I highly recommend is that you always have your little bottle of water to spray full next to where the toilet bowl that you use to pee. So that way, if you have like the little scratches on top, you can just spray water because urine is acid, so it can burn a little more. But if you're spraying water, you're gonna see it. It's so relieving. So don't be afraid of passing a stool, even if you had a third or fourth degree tear. I had that at my second baby, and it was not that bad, far from there. You can take sitz baths after a couple of days of giving birth, but you have to keep your knees like glued together, so no stretching on the stitches. I've had a patient that came to my office and she goes, I feel the stitches were too tight, so I did the split. And of course, the stitches split, and then it's too late because there's bacteria on the skin, so we cannot reclose. Because then you're gonna do, if you reclose the skin on the bacteria, you're gonna do a big abscess. So it healed on its own, and it healed larger. So the second baby, she did not need any stitches. And by the way, if you have stitches at your first baby, it doesn't mean you'll have stitches at the other one because your tissues has been stretched. You're never the same once you give birth. Let's say this. I've had a fourth degree tear for my second baby. First one was born through cesarean, and my two last ones, I had absolutely no stitches. So it's possible, and it's actually common. So don't worry about that. Kind of a weird story. I had a patient that delivered, she had big babies, two 9 pounders, like first baby, second babies were above 9 pounds, no stitches. Third baby was 7 pounds. She went in labor like a week and a half early or something like this. And, sure enough, I barely made it to the hospital and the baby came out. And then I look and she tore. So what happened there? She didn't tear for the two big ones and she tore for the small ones. It's just that the baby came out so fast that it did not do the rotation for the shoulder. So both shoulders came out at the same time and it tore her. But we were like, man, you need stitches after having two babies without stitches. But, anything can happen. So if you're taking baths after a couple of days of getting home, don't take it too warm because that the stitches are dissolvable. You don't need to have them removed, but you don't want to have them melt too fast either. Okay, so not a cold bath where you're shivering, but lukewarm is okay. No bubble baths, no nothing, no bad bombs, of course, because that would be the bomb. And so nothing, just soaking yourself. If you feel like, with the bleeding after having the baby, you feel like kind of not dirty, but almost just, and they call it sits back. If you feel like you're uncomfortable touching the bottom of the tub, you can always, it's not worth buying those inflatable donuts because you're only going to use it for a couple of days, even like outside the bath. Same thing if you sit. You can always fluff up a big towel, put it in a round circle, and then your buttock doesn't touch the. Make sure that where your bottom is, it doesn't touch the tub. Same thing if you're sitting, just fluff up a towel and refluff it and do a donut with it, and then you have like air, so you're not sitting on directly on your stitches. You could do what they call padsicles, which is basically a pad that you kind of freeze. So, or any kind of ice is also very good, especially the first 24, 48 hours. That's when sometimes you get swelling because, again, if you pull on my lips, you remember we had like big mouth. So same thing, you had a baby coming out of there, but it recuperates very fast. So here's my demo. Again, my nylon here. So that's the baby's head coming out. That's the vagina, the round thing, and that's your anus right here, the little brown spot. You didn't wipe enough. So the baby's head is coming out, and I'm gonna. I have to rotate the baby like the baby would rotate. So patient is pushing, pushing, and it's not coming out. So what they would do is they would take the scissors and cut here. They don't need to go all the way down here, and that would free the baby's head. Like the baby's head would be able to come, like my baby's born right here. And that's first degree tear, second degree tear, third degree is to the mucus of the entrance of the anus, and the fourth degree tear is the anal muscle. And then we stitch up everything, and they're dissolvable stitches. So, hey, my baby's born here. So the argument I was telling my patients about not doing routine episiotomy, I was before my time, I guess, because now the American Association of Gynecologists says less than 10% episiotomy is what we're aiming at. So is that my fabric here is very, very solid. If I tried to rip it off, I could not. But as I was telling my patients, if you go to the store, they do a little cut with good scissors. So let me get the good scissors. And you see the tear. Okay, once it's weak. I'm sorry if I created some discomfort by my demonstration, which is kind of violent. You never tear that much. I'm just saying that once you create a weakness, it goes down. So that's the biggest argument against routine episiotomy, which is not the case anymore. But discuss it with your healthcare provider. So please comment below. Tell me your story. If you had a tear, if you had an episiotomy, what you think of it. I've heard of women getting episiotomy without even it being discussed. Like they were told after, yeah, I cut you, and it's like you have rights, and what they call informed consent is that they have to ask your permission. Sometimes it's the discussion will be short, like, okay, this is the situation, the baby is not moving and the heart is crashing, so I highly recommend an episiotomy, and that's it. Remember, I promised you a surprise if you stuck around so until the end. So here it is, the ring of fire. So what women describe as the ring of fire is once the baby is crowned, the skin is so stretched, and the nerves and everything is so stretched that it's an intense burning feeling around the baby's head with all the tissues being stretched. There's a way around this very easily. When we prepare for the birth, the nurse pours a little mild soap that we use, like a disinfectant. So I would have some left over in my little bowl. So once the baby was like this, and my patient would say, "Oh, it burns," I would pour some liquid, and they would feel immediate because it had cooled down at room temperature. So my patients would feel immediate relief. So I would just pour, and I felt like I was doing something, and my patient appreciated it. One of my patients was really like, "Oh, pour the water, pour the water." And at one point, the baby was really, really crowned. I could almost see like his eyes color, so I knew he was going to born the next one. And my patient screamed, "It burns! Put some water, Natalie, put some water." And I look at the bowl, and the bowl was empty. So I'm like, oh no. And the nurse rushes to bring me more of the disinfectant. But sure enough, my patient pushed, and the baby was born. And the second the baby's born, you don't feel anything because the pressure is relieved by the baby passing. So it's really a relief. There's another PS. So it's been 4 to 6 weeks since the baby was born, and you had your stitches for either the episiotomy or some tearing. You saw your doctor or your midwife today, and they said everything's fine, everything's healed up. You can have intercourse, resume intercourse. You've had a romantic dinner, blink, blink, and your spouse was giving you the soft eyes, so you know he's ready, but are you ready? So first things first, don't be afraid. Nothing will be wide open or nothing will pop open. Don't worry about that. You have to know that scar tissue is more fibrous. It has less elasticity. Let's say you cut yourself on the arm here, you're gonna have a scar which is like more fibrous than the original skin. So you're gonna see a difference, and it's usually like less stretchable. That's normal. There's nothing like the original tissue. So down there, but the vagina is stretchable. So one trick that I find is that's a good reason to do perineal massage. So you can put your thumb in there and you just stretch the tissue. You might feel like little knots because when we do the stitches, we close them. So just like your shoelaces, you have knots. So it's the same thing. But if you massage them, eventually it will get like really softer. If you do it and you're too tense and you're ooh ah and it hurts, just play cards and tell your spouse, well, sorry, not tonight, or have fun in another way without a penetration. But eventually, you might want to do the perineal massages and get the tissue back to its elasticity. And actually, the elasticity comes back with use, if you know what I mean. So the more active you're going to be, use birth control, of course, if you don't want a second baby right away. Even if you're breastfeeding, that's not 100%. So just do the perineal massages, and that will tell you if it's okay. That means the intercourse will be okay. If it's too tender, you just discuss it with your spouse and keep doing the massages, and eventually you'll know that everything's fine and you're ready to resume your normal life.